There's just one issue that I didn't really touch on, which I think deserves some discussion, and that is when the patient comes into your emergency room and people are rushing around and wanting to give TPA, and then that patient gets better, people go off the boil and they are no longer a hot stroke, and it's worth remembering that that group of patients, which is about a third of them are dead or dependent at discharge from hospital. So just because you've decided you're not going to give TPA because somebody's getting better, don't forget that their risk is really high. And there may be a number of reasons for that. And with the advent of CT angiography, we're able to, there's a number of instances have an occlusion, but their collaterals are good, they've kicked in, and they're kind of resurrected for the time being, but only temporarily. So it sort of broadens the scope of the kinds of patients. It even broadens the window a little bit because there may be things that need to be done. They still may need to be investigated. And so there may still be a reason to fire up the telestroke to get some input about what's going on, get a neurologist to have a look at the patient. There may be more clinical deficit than is apparent. So it's nice to try and move away from the complete train wreck stroke sometimes that gathers all the attention and for which in many instances we can't do as much for, and pick up some of the low-hanging fruit where there's less disability but a lot more to gain.
The evaluations from our telestroke consults when they were reviewed, the telestroke consult, whether or not TPA was administered, the consultation was viewed to be universally helpful. So that sort of speaks to what Andrew was saying. It's not just pulling the trigger on giving TPA. It's providing helpful advice as to medical management, further investigations, etiology, and so on. And the one lesson I learned running our local network here is that in order to make this thing work, you really need a local champion at your hospital who is just enthusiastic about setting up acute stroke care and developing a local TPA program. And so for those of you at other sites who are interested in providing this service to your patients, identify a couple of local champions. And I think that's sort of the energy that we're going to need to the next step, which we would envision maybe 20, 25 sites around the province that could potentially offer this service. So we've got a ways to go, but if you get some local champions working on it, it'll be hugely helpful.
Great. Thank you, Phil. And thank you, Andrew, for taking the time to do this presentation out of your busy day. Andrew and Phil are asked to support the telestroke planning and other stroke planning on an ongoing basis. And I think that's the comment around the neurologist. Some of the challenges is that in order to get telestroke up and running at a provincial level, you really need the neurologist, the champion neurologist.
Okay.
There's still a lot of feedback from one site that hasn't muted. I think they're having their lunch now. So I'm going to make this short and sweet, but I just wanted to thank them very much, not only for the presentation, but for bringing telestroke to where it is today. And I thank all the sites for joining, and I apologize for the technical difficulties. It seems that at a larger scale video conference, it's very challenging to coordinate. And as a province, we're continuing to work on that. I'd like to remind the attendees that this is a CME accredited, so if there is a sheet there, if you could complete it with the appropriate information, and that needs to be forwarded to 25059, faxed it seems, to 1-250-592-8041.